Sorry, it's funny, unmute button there. Thank you for having me and letting me talk today. Um, Excited to do this, and thank you for everyone for coming. So my presentation is about a paper I published, and the title is "Collateral Circulation of the Femoral and Genicular Systems is in Human Lower Limbs is Highly Uncommon." And this was performed during my graduate studies at UT Health San Antonio and the mentorship of Dr. Rahimi. So let's first primarily look. Let's first look at the primary arterial blood supply to lower limb. Blood first reaches the lower limb by the external iliac artery. As across the inguinal ligament, it is renamed the common femoral artery. This divides into the superficial femoral artery and deep femoral artery, or also known as profunda femoris. Blood continues down the thigh to the superficial femoral artery. As it approaches the knee, it is renamed the popliteal artery before it continues down the leg towards the leg. Now that's the main pathway. But collateral pathways also exist. These are alternative pathways to blood to reach a destination, which can be used to reroute blood around an occlusion. Think of using a feeder road to circumvent a traffic jam on the freeway. The feeder road reconnects to the freeway via a ramp. When blood vessels do this, this is called anastomosis. This can be seen in the lower limb. Oh, excuse me. That's what I was going to say. So anastomosis will occur here, and this can be seen in the lower limb instead of going through the superficial femoral artery, blood will go down the profunda femoris artery to the lateral circumflex femoral artery. A branch of this is the descending branch, which travels down the lateral aspect of the thigh and connects to the superior lateral genicular artery, which is a branch of the popliteal artery. And this is anastomosis, and this is what is conventionally described by anatomical text. This is the primary collateral pathway for blood from the proximal portion of the lower limb to reach the knee and beyond. Now, collateral circulation is very important when certain pathologies are present, such as atherosclerosis. This is a blockage in the vessel leading to reduced blood flow. Here we can see a clean, normal vessel, and I will put the pointer on if that will help. Don't mind me. Okay, I'm not sure that worked. Sorry about that. Okay, okay, my mouse is okay. There we go. So here we see a clean vessel with a nice wide lumen, while here we see a vessel with an atherosclerotic plaque buildup. So this leads to the narrowing of the lumen of the vessel and reducing blood flow. There increased blood pressure, leading to even further hardening of the vessel walls and reduce the elasticity of the vessel wall, thus increasing vessel resistance to blood flow. So in fact, in the proximal portion of that superficial femoral artery, this is actually which is the main pathway of blood down the lower limb, is a very common site for atherosclerotic plaque buildup. Excuse me. Complications of atherosclerosis include peripheral arterial disease, where there's reduced blood flow to the limbs, and typically this is more common in the lower limb. In extreme cases, chronic high blood pressure may lead to aneurysm, which is a weakening of the vessel walls, and even further acute limb ischemia, where suddenly blood cannot reach the lower limb. Collateral circuits can alleviate some of these concerns and allow blood to circumvent these occlusions and maintain some blood flow to the lower limb. And in the lower limb itself, this is that descending branch I described earlier. That's the primary source of collateral blood supply. The descending branch is also very important in reconstructive flap surgery. This is a type of tissue graft, for example, skin, but instead of taking just the visible layer of skin, the underlying subcutaneous tissue from the area of the body is included and moved to in order to repair a wound or defect. One type of reconstructive surgery is the anterolateral thigh flap. This uses a large area of skin on the anterior and lateral aspect of the thighs, you can see here, so it is versatile. More importantly, the descending branch has perforating vessels that directly supply the skin. So because this piece of skin is well vascularized, it is a reliable flap. Thus, the vessel remains attached to the skin during this procedure. There are two types of flap surgeries for the anterior lateral thigh. A free flap, where the skin is detached and the vessels are cut at both ends and can be used to repair any area. One example is you have scalp defects. We see necrotic skin here covering the cranium, and then it's debrided, flaps attached, and now the defect's been fully fixed. Another example is breast reconstruction. This patient has had a mastectomy, and you can see the pre-op outline on the skin of the flap that will be used for surgery. Now procedure has been done, and now the flap has healed. That's a free flap. Now, the second type of flap is a pedicle flap. For this, the vessel is cut only at one end, and there's the proximal end, and then the flap is turned into position locally. So we'll see here. So here we have the piece of skin from the thigh, and you see it's flipped around and moved towards the knee. And you see how the vessel remains attached to this flap. In fact, they've even made a pathway here to be able to reimplant that vessel in the inferior direction. Now, this is a distal pedicle flap. For this flap, since the descending branch is cut at its source, proximally, it must connect to another vessel inferiorly in order to receive retrograde blood supply to the flap to keep it viable. So blood coming down the leg and coming back up into the flap. Thus, the anastomosis is highly critical. Now, the dogma for this surgery is that the descending branch anastomosis with the superior lateral genicular artery right here. But there's some issues because there's great variability in the anatomy, including in the origin of the descending branch itself. Now, sometimes anastomosis may be present, sometimes, sometimes anastomosis is present, but either only one of the vessels is involved, here, or neither involved. So maybe this vessel doesn't actually anastomosis this one, or vice versa. So perhaps no anatomy occurs. Perhaps no anastomosis occurs whatsoever. But since we don't know its true source, for the purpose of the study, I refer to it as the descending arch of the thigh, as opposed to the descending branch of the lateral circumflex femoral artery. There will be some longer terminology used along the way, and I hope to not be too confusing. So apologies in advance. Our past studies confirm that there's high variability in the origin of the descending artery of the thigh, and the presence of its anastomosis with the superior lateral genicular artery. The typical branching pattern of the descending artery occurs between 30 and 80% of the limb dissected, while typical anastomosis only occurs between 46 and 80% of limbs. Now, many of these studies have been performed in South Asia, but there was no known studies in the United States. Thus, we looked at to study the differences in the behavior of the descending artery in the South Texas population, but also trying to speculate why these differences may occur. So first thing first, two aims: establish the source of the descending artery, the true source, and then classify the types of anastomosis that might occur further down into the knee. Hypothesize that the typical source and branching pattern of the descending artery will be most prevalent, but actually the descending artery will not be the primary source of the anastomosis, but instead it will be the profunda femoris directly that will anastomose with the superficial femoral artery. Our cohort consisted of 51 limbs, compiled of 24 cadavers, each with a pair of limbs and 3 individual limbs. So then we were able to compare some bilateral anatomy also. 26 males and 25 female limbs, and all donated from the South Texas region. One thing to preface, we had no patient history regarding the origins and the health records of these of the cadavers themselves. So in order to complete the first name, we had to open the femoral triangle. This can be accessed from the superior and medial aspects of the anterior thigh, like you see here. After dissecting away skin and underlying fat, many neurovascular structures can be seen. These are the femoral nerve and vein, plus the lymphatics, but more importantly for our study, the location where you have the common femoral artery branching into the superficial and profunda femoris arteries. The large vessels were dissected and traced until the descending artery was found, traveling on the lateral aspect of the anterior thigh, and its source and branching patterns were noted. So this is the typical one as anatomically expected. And for the most part, we did see that. Of 51 limbs that are analyzed for this study, 62%, so 32 out of 51, show that typical branching pattern. So you have the common femoral artery, the deep femoral artery, then the lateral cervical femoral artery from that, and the descending artery off that from there. And that's typically described in anatomy text. We did see some interesting asymmetry as well, but we saw some other other atypical branching. So we saw about 10% of our cadavers had descending artery coming directly off the superficial femoral and not this lateral cervical femoral. We had 6% coming directly off of the deep femoral artery, and we had 4% coming off the common femoral artery, so before it even splits into superficial versus deep femoral arteries. Another 6% came where the descending artery came off the lateral circumflex femoral as expected, but that itself did not come off the deep femoral, but off the superficial femoral instead. Same thing here, where again it comes off the lateral circumflex, but here it comes off the common femoral as opposed to the deep femoral artery. There was a couple of times where we saw a common trunk where you had the profunda femoris and the lateral circumflex coming off together, and one instance where we had descending artery coming off together with the lateral circumflex. This just shows the variability of anatomy that we see. And also reminds us that because we saw some asymmetry where half the limbs from a pair of limbs of cadaver, half of them had different branching patterns from each other, it just reminds us that each limb should be analyzed individually. So now that we've classified the sources of the descending artery, it was time to see how often that branching pattern exists with the anatomically conventional anastomosis as well. So for this, we have to access the popliteal fossa. This can be done from the posterior aspect of the knee and diamond-shaped region flanked by four muscles, as you can see here. Now, once the skin has been reflected and the adipose tissue removed, the neurovascular structures become visible. Now they're in the popliteal fossa. The superficial femoral vessels are renamed the popliteal vessels. Now, these are separated, and the popliteal artery and its branches are traced superiorly to see if they connect with any vessel that traveled from the superior region of the thigh, looking for this collateral circulation. The vessels we look at in particular are the superior medial and superior lateral genicular arteries. Now, superior lateral genicular is the one that we expect to be the most common anastomosis. During the dissection itself, these vessels do get quite small as we go distally towards the knee and from the knee upwards. The vessels do get quite small. So many vessels came close to one another, specifically within 20 millimeters, but no physical connection was visible to the naked eye, and these were classified as an approaching anastomosis. This protocol was established in a previous publication in order to account for microscopic connections that are not visible, but like you said, exist. And we just can't see them to the naked eye. And also there'd be risk of, if you go further in, breaking those capillaries and really small arterioles. So to make sure that we maintain that tissue and kept it intact, we had this approaching protocol. I hope that makes sense. So here we categorize what exactly we saw in these limbs, and I'm going to have this diagram on the side will kind of illuminate that along the way. So in 72% of the limbs in the study, no anastomosis was present. So this is a vast contrast to what we've seen in previous articles. Thus, there'd be no collateral arterial connection between the proximal and distal region of the thigh. 14 limbs, 14 limbs presented single anastomosis. Now we look at their specific types. So 10 of the 14 we had with the descending artery of the thigh, and 4 of them are from this deep femoral artery. So let me describe these ones first, the descending artery. In 6 of the 14 limbs, a normal anastomosis was observed. This is where we had a physical connection between the descending artery and the superior lateral genicular artery. In 4 of the 14, the same two vessels reached within 20 millimeters of one another, but no physical connection was visible, though micro connections are believed to be present. Now, in the other 4 limbs, atypical anastomosis was seen. 2 of these were between the funda femoris and the superficial femoral artery itself, where a distal perforating branch of the deep femoral artery continued to travel, and that is what connected with the superficial femoral artery before reaching the popliteal fossa. And the other 2 cadavers, other 2 limbs, there was a distal perforating branch of the profunda femoris. That is what connected with the superficial lateral genicular artery directly. So again, comparing these two, one is the deep femoral artery connecting to superficial femoral artery, and one is connecting to the superior lateral genicular artery. So this final one turns out was an exciting find because I had not yet seen it and previously described in known literature. So far in the study, we have seen that typical anastomosis were not usually present. Now, why were they not present in everyone as described in anatomical text? Because you see a text, you see an atlas, and you assume, okay, that's going to be there for everyone. So why aren't we seeing these? Firstly, no patient history was available, so we don't know what risk factors for atherosclerosis the patient may have had. Therefore, we could not predict when and why the anastomosis formed in some and not others. We don't know about possible genetic reasons. Maybe anastomosis formed during development, though these may not explain the laterality of the anastomosis. The same set of genes would be used to develop both limbs, thus perhaps some environmental factors cause the differences. We also don't know what physiological reasons that are taking place, but we wouldn't have been able to test these in a cadaveric study anyway. And we know that arteriogenesis is occurring, so existing collateral arteries are being remodeled, which would be triggered by physical forces such as an increase in pressure in order to help offset the decreased blood flow. Also, there's a law called Parcell's law that states that blood vessel resistance is inversely proportional to the radius of the vessel to the power of 4. Therefore, as the radius and thus diameter doubles in size, resistance to blood flow actually decreases by 16-fold. Therefore, larger blood vessels have greater blood flow. Right? This makes sense. So considering that collateral circuits develop to offset decreased blood flow in theory, and larger vessels have increased blood flow, we thought, what if these collateral circuits only exist if the major vessels are narrower, since they are not necessary in these situations? Back to the freeway analogy, if the freeway is wide enough, 6, 7 lanes wide, how much do you even need to use the feeder road to bypass traffic? And if so, do you need the feeder road? Whereas if you have a narrow freeway, 2, 3 lanes, more likely for traffic to occur, you might need to use a feeder road more often to get around that traffic jam. So that led us to ask, does vessel diameter influence the presence of an anastomosis? So this led to a third hypothesis of this study. We hypothesized that the presence of anastomosis will be dependent upon the diameters of that superficial femoral artery and the descending artery of the thigh. So comparing these two, so comparing the main highway versus the main feeder road, let's say, and as the diameter of the superficial femoral artery would increase, the likelihood is that normal anastomosis occurring would decrease. And the opposite would be true for descending artery, where the increase in diameter in that mean less likelihood of an anastomosis occurring between the descending artery and superior genicular artery would also increase too. In order to test this hypothesis, we developed an initial aim as here. So compare the diameters of the descending artery and the superficial femoral artery to the common femoral artery, determine if a correlation exists between vessel diameters and the presence of an absence of anastomosis. Because we had limbs for both studies, we had to, first of all, we did vessel diameter at origin using a caliper like so. We took an average of 3 measurements and then used 50, and then is also in 51 limbs. And because we had limbs from cadavers of various sizes for both sexes, we had to normalize the data to be able to compare all subjects into a singular analysis, no matter how large or small. You imagine a larger individual would have larger, wider vessels than a small individual. And obviously there will be differences between male and female sexes too. So this is how we normalize the data. We created these vessel diameter ratios. So stick with me here. So imagine you're comparing the diameter of the superficial femoral artery to the common femoral artery to see how wide it is in comparison to that. Same with the descending artery in comparison to that. So that way we can normalize between, because you'd expect in an individual with larger vessels, everything's larger. Same with people with smaller vessels, everything's smaller compared to the person with larger vessels. So we normalize it to each other in its own cadaver, in its own limb. That way we could then have a more accurate ratio to describe how big the arteries are in that individual. And then we formed a ratio for each cadaver and took the mean of the ratios, because we did the measurements 3 times, we said, and then for all 51 limbs. So why are we comparing these two vessels? So we're comparing the superficial femoral artery to the common femoral artery to determine. We are seeing if differences in relative vessel diameter to each other when anastomosis are present versus absent when looking at the primary pathway of blood flow down the lower limb. Same thing goes here. This way, looking at the primary collateral flow to the lower limb again, and seeing if this is wide compared to its source. Does that mean it's less or more likely to have an anastomosis in there? Now, to do this comparison statistically, we use unpaired student t-tests comparing the vessel diameters to the vessel ratios to each other. So in the primary pathway, which is comparing the superficial femoral artery to the common femoral artery and whether there was an anastomosis or not, that's what none versus normal means. None means no anastomosis. Normal means has a normal anastomosis. We excluded the data sets for the atypical anastomosis because that wasn't the focus of this hypothesis, because we're looking at the descending artery itself. The atypical ones, descending artery wasn't involved, so it wasn't included in this portion of the analysis. So here we see any differences between the superficial femoral artery, the common femoral artery, and whether anastomosis is present or not. Here we see in the red that these limbs lack anastomosis, normal had anastomosis. So on this unpaired student t-test, we saw a significant difference between the two categories. Thus, when comparing the diameters of the superficial femoral artery to common femoral artery, the relative vessel diameter in limbs that lacked anastomosis is significantly larger than had anastomosis, suggesting that the major highway for blood is wide enough that collateral circuit is not needed. Essentially, this freeway is 8 lanes wide. You don't need to make an anastomosis because this is wide enough as it is. So then we compare the collateral pathway and see any differences there. Here again, we see in the red, we see these limbs did not have anastomosis, these limbs did have anastomosis. On this t-test, we did not see any significant differences between these two categories. So in comparing the descending artery of the thigh to common femoral artery, there's no significant difference in relative vessel diameter in limbs that lacked anastomosis than limbs that had anastomosis. So essentially, no data to suggest that if this is wide enough, an anastomosis will be formed down later, formed distally. We also wanted to see if it's possible to predict the presence of anastomosis by the type of branching pattern of the descending artery of the thigh. So a quick contingency table was created. Essentially, the branching pattern does not predict the presence of anastomosis at all. So in conclusion, we found that in analysis of the descending artery and the collateral blood supply, the typical branch pattern was about 62% in limbs, with typical anastomosis observed in only 90.6% of limbs. Now, looking back to historical data, we saw that there was a wide variety here and here. So it's not unexpected that we had a very wide difference in our numbers too. The superficial femoral artery had a small diameter relative to common femoral artery when a collateral circuit is observed and when a collateral circuit is absent. So this was our suggestion that when the superficial femoral artery is wide enough in diameter, a collateral circuit is less likely to be required. And the source of the descending artery does not determine if anastomosis occurs. And we also found a potentially novel anastomosis between the funda femoris and the superior lateral genicular artery, which is unreported in previous literature. This is the first study to combine analysis of the collateral blood supply with branching pattern and diameter size of vessels, confirming the lack of typical anastomosis of the descending artery of the thigh. There were some limitations to this study. There were difficulty dissecting the descending artery as it narrowed in the distal regions of the thigh, as I mentioned earlier. Here it became very weak and wispy, and further dissection could have removed the possibility of visualizing anastomosis. There's another reason why we chose to adhere to the approaching protocol as described by our previous study, as it suggests to halt dissections if vessels are narrower than 0.5 millimeters and within 20 millimeters of one another. And because previous studies had indicated that imaging studies in cadavers are not as reliable as dissections, we opted to measure external diameters rather than internal. But truly, the internal diameter is what's actually determining these physiological changes. Importantly, internal diameter, when measured using duplex sonography, is closely related to external diameter. So there is some correlation, but again, not exact numbers here because we didn't use internal diameters. Last, we cannot account for when and why the anastomosis formed because of the cadaveric study. That's why we attended our third aim, to try and learn more about the existence and kind of speculate why they may be occurring in the first place. Just some further questions posed by the study. Why anastomosis generally present unilaterally? A quick look at the data. I didn't show that in this slides. Quick look at the data we had was there wasn't necessarily any bilaterally. So bilaterally similar. So just say there was one limb that had an anastomosis doesn't mean the other limb had an anastomosis too. So that'll be things we can look in the future. Then would the descending artery be wide enough to sustain collateral circulation even if an anastomosis formed? So, the superficial femoral artery and the descending artery are vastly different diameter. One's a very main highway, one's a feeder road, as we said. If there was an occlusion in that superficial femoral artery, would the increased blood pressure that goes to the descending artery, would it be able to handle it? We don't know that. Now, we also, speaking of Poiseuille's law, also describes how length of a vessel is directly proportional to vessel resistance to blood flow. So that perhaps also has some influence. The longer the vessel might be, it also would increase resistance, which could also decrease the likelihood of a anastomosis. We don't know. And lastly, how does diet alter development? It's known that poor diet management and overconsumption of foods with high cholesterol and sugar are risk factors for atherosclerosis. And as discussed earlier, the increased blood pressure in vessels caused by plaque buildup causes collateral circuits to remodel. Thus, you wonder how diets can affect the development of anastomosis. And just finally, the study suggests that prior to performing distal pedicle anterior lateral thigh flap surgeries, check for viable anastomosis to ensure flap survival. As you said, the anastomosis might not be present as expected. And lastly, when looking at anatomical atlases and images of vasculature, and when one sees the vessel connection in the image, one would believe that these occur regularly, if not all the time. And we must stress that they do not always occur as expected. And here are my acknowledgements. Thank you for your time.